Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Nikki Keefe. She's an interventional radiologist. Today's Kevin MD article is Overcoming Disparity in Access to Uterine Artery Embolization. Nikki, welcome to the show.
Thank you so much for having me, Kevin.
So, we talk about the article in a little bit. First off, just briefly share your story and journey.
I'm an interventional radiologist at the University of North Carolina. I hail from Buffalo, New York, so it's a little bit different down here.
Mm-hmm.
We chose to study the health disparities that patients undergo when it comes to treatment of their fibroids. Fibroids are super common and can affect up to 80% more common in African American women than white women or Hispanic females. But it's very common, and the most common procedure performed these days is a hysterectomy. But there's a
Mm-hmm.
lot of other options for them, and that's what we sought to evaluate is those disparities among patient care for the treatment of their fibroids.
Perfect. So let's jump straight into that article. It's titled Overcoming Disparity in Access to Uterine Artery Embolization. Now, before going to the article, just to get everyone on the same page, just give us a 30-second primer in terms of what a uterine fibroid is.
Perfect. So uterine fibroid is a soft tissue, benign tumor within the uterus. It's just an abnormal growth there. It can cause a bunch of different symptoms that we categorize into bleeding and bulk. So the bleeding related symptoms, heavy menstrual cycles, pain associated with menses, intermenstrual bleeding. It can be really devastating to a lot of patients. Bulk related symptoms due to just the size of the fibroids pushing on adjacent structures, frequent urination, constipation, back pain, abdominal pain, bloating, those kinds of things. It can really affect a female's quality of life.
All right. In terms of potential next steps forward and that intersection, of course, between interventional radiology and the treatment of uterine fibroids.
So there's a lot of treatment options. The first being you can do nothing. A lot of people will live with them, and either they don't know they have them or they've just been living with them so long they're used to it. You've got medical therapy options. Most of them are a form of birth control or medication that will help decrease the bleeding, but you have to take it forever until you reach menopause because fibroids are hormonally dependent. There's endometrial ablation where they go and they burn the uterine lining in order to stop the bleeding, but it only helps with the bleeding related symptoms. Uterine artery embolization, which is, of course, what I do and my focus here, which is a minimally invasive treatment in order to block the blood supply to the fibroids to decrease their size. There's myomectomy, where they can cut out the fibroids. That can be done either through a laparoscopic approach or a transvaginal approach. And then there's ultimately a hysterectomy, where they remove the entire uterus, plus or minus the fallopian tubes or ovaries to treat the fibroids.
And to focus on uterine artery embolization, who would be the right candidates and what type of fibroids would be more amenable to that approach?
Yeah, we've done a lot of research over the past 20 years to evaluate that exact question. And historically, there were a lot of patients that may not have qualified, but the vast majority of patients these days qualify for uterine fibroid embolization. They can have gigantic fibroids, they can have small little fibroids, they can be pushing on the endometrial canal or on the other side of the uterus towards the peritoneum. They can be hanging off into the uterine cavity. All of those fibroids qualify for uterine artery embolization. The only caveat being that for patients that desire preservation of their fertility, we don't have great data on that. It's so hard to study prospectively those patients. While we've seen plenty of patients get pregnant afterwards and have successful pregnancies, we just don't have the data to say it's the equivalent to a myomectomy yet.
So, what exactly is that procedure like for the patient?
The vast majority of practitioners these days go through the artery in the wrist. We take the long winding route down to the artery that goes towards the fibroids. There's one on each side, each uterine artery. Sometimes they'll go through the artery in the groin instead if you don't qualify for the artery in the wrist. We put tiny little particles into the arteries that supply the fibroids to block off the blood supply. Some people will put lidocaine in the arteries. Some people do a nerve block. Some people just do postoperative medications in order to help manage the postoperative pain. The recovery for a uterine artery embolization is about 1 week, so pretty short. And patients can expect to see their bleeding symptoms significantly improved by 3 months and their bulk related symptoms significantly improved by 6 months. So it does take a little bit of time because we're talking about shrinking down those fibroids. I liken it to as if you plucked a grape from a vine. It's going to turn into a raisin. It's never going to disappear. It's still there, but it's not functional. So it takes time, but we do see really good results with preservation of the uterus. We have data that shows that 10 years out, we're preserving more than 60% of uteruses for patients, which, a lot of people don't want that big surgery that comes with a hysterectomy.
And in terms of outcomes, how does that approach compare to some of the other treatment modalities, say myomectomy or hormonal therapy?
Yeah, we have great outcomes that at 2 and 5 years post UAE, the outcomes are equivalent to myomectomy and hysterectomy in terms of quality of life factors postoperatively.
All right. So in your KevinMD article, it's titled Overcoming Disparity in Access to Uterine Artery Embolization. So talk more about that article.
Yeah, so what we look to evaluate is how uterine artery is faring in comparison to these other procedures over the past 10 years, and really demographically, is it equivalent for patients who are of different socioeconomic status, different regions within the country, different racial and ethnicity status, insurance, income, all of those different things. And we did see some areas of disparity, which was, sad to see, but really allows us to focus on those areas in particular. So if I start off with the background, we see about 80% of women get a hysterectomy for fibroids. About 20% get a myomectomy, less than 1% get an endometrial ablation, and only about 2% get a uterine artery embolization. So it's really not a common procedure yet, even though our national society has been pushing and advocating for this procedure for patients. We do see differences between non-Hispanic whites, non-Hispanic Blacks, and Hispanic patients. Blacks account for the vast majority of patients that have fibroids, and yet we see that they are actually more common to get a uterine artery embolization than other procedures, than a myomectomy or hysterectomy, which I found very interesting. Across income levels, it's pretty equivalent. Across insurance levels, we're seeing an increased number of patients in the Medicare population getting inpatient procedures with a decrease in private practice. And I think that's because a lot of patients are getting outpatient uterine artery embolizations. Our study was really focused on the inpatient setting. So we're seeing a lot more Medicare patients in the inpatient setting. But the most interesting one to me was in the rural urban setting. So the vast majority of patients get their procedures done in urban teaching environments, whereas only 1% of patients get it done in a rural center. And there's a lot of patients out there in the rural setting that just aren't getting access to the care that they deserve.
So in terms of this procedure, what is the penetration of this being done, say, at a community hospital that could be more amenable to a rural setting?
Yeah, so about 20% of the proportion of procedures that are being performed are done in a community setting, not in an academic center. So it's still a fair amount of patients that are being able to get this procedure done. Some of the differences that because our data was based on inpatients, a lot of rural or urban non-teaching hospitals or community-based hospitals, a lot of private practices will do their procedures in an outpatient setting. So we're not capturing that portion, but there are other studies that have captured that and are showing that, the proportions are still the same. It's still a lot less people that are getting UAE done and compared to myomectomy or hysterectomy.
So in terms of the racial disparities when it comes to access to UAE, what are some potential explanations that can lead to those findings?
So we found that Hispanic patients were actually less frequently offered or underwent uterine artery embolization compared to others. That may be due to language barriers where patients don't get access to care, or they just don't understand quite what's going on due to lack of translators or appropriate language. But also, a lot of it has to do with community, where one person gets a procedure done, they love the results, they tell it to all of their family and their friends. And if we don't capture the Hispanic population, then it doesn't spread as much by word of mouth as it would in other communities.
So I have a question in terms of the pathway to getting to an interventional radiologist. Typically, I'm a primary care physician, internal medicine. If I see someone with symptomatic fibroids, I will send them to a gynecologist. And intuitively, that will lead me to think that they will do some type of gynecology-based procedure. Now, in general, are they the ones who would refer people to UAE?
That's a great question, and something that I think within the entire spectrum of IR, we we have challenges with that because we don't own necessarily the patient. Like gynecology will own a fibroid patient, and urology will own a prostate patient with BPH. It's very similar type of disease pathology. But typically the patient will go to their gynecologist, they'll get an endometrial biopsy for increased bleeding, they'll get an ultrasound that evaluates the fibroids, and the gynecologist will talk to them about their treatment options. We have seen a lot of patients come through our clinic that say that they were never even offered a uterine artery embolization as an option. So we do get a lot of patients. We have an amazing relationship with our gynecologist at UNC. So we get a lot of referrals straight from our gynecologist, but we also get a lot of self-referrals where they come straight from their primary care, their internal medicine doctor, what have you, after they found out about it through word of mouth.
All right. So in terms of these disparities, whether it's racial disparities or disparities as it relates to insurance, tell us some of the next steps that you see to increase access to UAE.
I think it's not really a problem of IR alone. Racial and economic and location, geographic disparities are a problem for medicine as a whole. You have to have the interventional radiologist in this rural community in order to have the procedure available to that patient. So that's one of the biggest challenges that people face. But another way that we can help with that is through multidisciplinary clinics, having a joint clinic with GYN where we see all of the fibroid patients together. So they're getting that evaluation from both GYN and interventional radiology simultaneously, hearing all of their options, making sure that all of the T's are crossed and the I's are dotted for their procedure. That can really benefit the patients, that they understand, everything of what's going on and, have all of their options available to them.
Now, is there an example of such a multidisciplinary approach? Perhaps that's not in an academic medical center. Like, are you aware of a story, or tell us a story where you've seen
Well,
that?
we had that at the University of Virginia where I trained, where we had that multidisciplinary clinic where we met with patients at the same exact time in the gynecology clinic. It was like once a month, every Monday, I think,
Yeah.
with our gynecologist. I don't know of one offhand in the private practice or non-academic setting, but I'm sure that they exist.
So tell us the future of uterine artery embolization. What do you see, something that's coming down the pipeline, and what can we expect regarding this therapeutic modality?
Yeah, I think that, like I said, over the last 20 years, we've done extensive research on this to really try and demonstrate that it is a viable procedure for patients with fibroids, and not just fibroids, but also adenomyosis. We're showing good results with that as well. Our society has worked really hard on promoting fibroid awareness and, allowing people to understand all of their treatment options. I think it's just going to take time of working with referring doctors, particularly in the primary care community and with OBGYN doctors. And then also patient directed marketing so that they understand their options in order to really reach out to a broad number of patients. And I think some of our marketing should be focused on the Hispanic community and on those underserved areas, whether they are rural areas or the non-academic hospitals, to really try and focus on, those other patients that we may be missing.
Now, for the patients who may be listening to you now, and even for me as a primary care physician, what kind of questions should patients ask themselves? What kind of questions should I ask patients to determine whether a uterine artery embolization may be right for them?
So I think that we as a community need to do better in educating patients and our referring providers. When a patient comes to a primary care doctor with heavy bleeding, with bulk related symptoms, I think it's important for the primary care provider to perhaps just start off with the basic basic ultrasound to see exactly what's going on.
Mhm.
If they have fibroids, of course they should be referred to a gynecologist. In no way should IR supplant a gynecologist, right? Because they still need the workup with an endometrial biopsy and those other kinds of things. But I really want the patients to understand that it's a multidisciplinary approach. Surgery and a hysterectomy in particular is not your only option.
Mhm.
There are ways that we can do minimally invasive, whether it's myomectomy or uterine artery embolization, and to not just be satisfied with hysterectomy as the only option.
We're talking to Nikki Keefe. She's an interventional radiologist. We're talking about the KevinMD article, Overcoming Disparity in Access to Uterine Artery Embolization. Nikki, will end with some of your take home messages that you want to leave with the KevinMD audience.
Thanks again for having me, Kevin. So my take-home message is for patients, uterine artery embolization is a great option for fibroids and adenomyosis. For clinicians, don't hesitate to reach out to interventional radiology. Just if it's a question, can we do this? Is the fibroid too big? Is it pushing in an area that's unsafe? We do a lot of combined procedures as well, where we do pre-op fibroid embolization for planning for myomectomy or hysterectomy in order to minimize blood loss for patients. So we really like that multidisciplinary approach. And don't forget to reach out to your friendly IR.
Nikki, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you.